Well, good afternoon, ladies and gentlemen. The topic for this afternoon's demonstration is the conduction tissue of the heart. What I'm going to do is start off by showing you and revising for you the disposition of the conduction tissue in the normal heart, and then I'll show you how this disposition is varied in several lesions with congenital cardiac malformations. But let's start off by looking at this normal heart, which you see on the screen at the moment, and let me take you through the arrangement for generation and dissemination of the cardiac impulse. I'm sure you're all aware that the cardiac impulse starts and is generated within the sinus node. The sinus node has a very constant position within the heart, and it's located here within the terminal groove. The terminal groove, as you all know now, marks the junction between the venous component of the right atrium. Here we see the superior cable vein. Here is the opening of the inferior cable vein. And that junction is with the appendage part of the right atrium. Now, in this particular heart, we have cut away the appendage from this position, but you can nicely see that having cut away the appendage, marking the site of the terminal groove on the outside is this very prominent muscle bundle from which the pectinate muscles of the appendage originate, and that is the terminal crest. And so the terminal groove externally locates the position of the terminal crest internally. So the sinus node lies within this terminal groove in a position that I'm indicating with the tip of my probe. It's a small cigar-shaped structure, and with the eye of faith you can almost see the sinus node in many hearts. And in this particular heart there is an area of yellowy tissue, fibrous tissue, and almost certainly this marks the location of the sinus node. So again, a small cigar-shaped structure, perhaps a centimetre and a half long, lying immediately subepicardial here within the terminal groove. In a small proportion of cases, the node sits like a horseshoe across this of the right atrial appendage, but that's very much the exception rather than the rule, and in the majority of cases it lies in the terminal groove lateral to the cavo-atrial junction, with a tail extending down the terminal groove towards the orifice of the inferior cable vein. Now, a lot of words have been written in the past about tracts of tissue extending from the position of this node and carrying the impulse through the atrial myocardium towards the atrioventricular node, which we're going to look at shortly. But in all our research, we've never been able to find discrete tracts of tissue within the atrial myocardium. These very prominent muscle bundles, such as the terminal groove, which we see here, the margins of the elbow fossa, the muscle bands between the holes within the atrium, such as the sinus septum here between the coronary sinus and the elbow fossa. These very prominent muscle bundles conduct the cardiac impulse generated by the sinus node at a pace more rapidly than does, for example, the musculature of the atrial appendage, but it is merely the packing cardiac cells within these prominent muscle bundles that encourage the impulse to travel more rapidly, for example, down the terminal crest than across the musculature of the atrial appendage. So there is preferential conduction through the atrial tissues, but there are no specialized tracts joining together the sinus node in the terminal groove to the atrioventricular node. As I say, we're going to look at the structure of the atrioventricular node very shortly, But let us stop for a moment and ask what happens when the sinus node activates the atrial tissues. The impulse generated by the sinus node spreads throughout the atrial tissue, running along the interatrial groove into the top of the left atrium. And there's another very prominent muscle bundle here running through the interatrial groove, which is called Bachmann's bundle. And the atrial tissues are activated throughout so that as they contract, they pass the blood and force the blood with atrial systole across the atrioventricular junction. Now, the impulse passes very rapidly through the atrial myocardium as it generates atrial activity, and equally rapidly reaches the atrioventricular junctions. It's important, therefore, to know that at these atrioventricular junctions, the atrial myocardium is separated from the ventricular myocardium. And if we concentrate down here on the right atrioventricular junction, if we look carefully into that area, we see that at the point at which the leaflet of the tricuspid valve takes origin from the atrioventricular junction, there is also a fibrofatty tissue plane composed in the larger part of epicardial fat, which insulates the atrial myocardium from the ventricular myocardium. And this insulation also occurs anteriorly, as you see here in the anterior support of the tricuspid valve, and indeed this plane of insulation occurs all the way round the right atrioventricular junction. Equally, it occurs all the way around the left atrioventricular junction. And if we look at this left atrioventricular junction, see here the atrial myocardium, here the ventricular myocardium, and the fibrofatty tissue plane separating together with the attachment of the leaflet of the mitral valve, the atrial myocardium from the ventricular myocardium. So in the normal heart, there is no way that the impulse passing through the atrial myocardium can reach the ventricular myocardium around either the left or around the right atrioventricular junction. Indeed, it is a function of the structure of the normal heart that only at one point does the cardiac impulse cross the atrioventricular insulating plane. And that one point is found here within this very prominent area in front of the coronary sinus. The reason for that, of course, is that when the impulse reaches the atrioventricular groove, it is little point in having the ventricle activated immediately following the atrium. We've already said that the purpose of atrial activation is to force the blood into the ventricle during atrial systole. The ventricle, of course, then requires time to fill before it contracts to force the blood out through the arterial trunk. So the purpose of the second part of the specialized tissue found here in the area I'm indicating at the moment is to delay the cardiac impulse so that the atrial blood can fill the ventricular chambers prior to its activation. And this delay is produced by the atrioventricular node lying here in the apex of the triangle of Koch. Now the landmark of the triangle of Koch, the landmark to the position of the atrioventricular node is this triangle of Koch. And this is formed by a fibrous structure that passes forward from the junction of the Eustachian valve, which you see here, guarding the opening of the inferior cable vein, and the Trapesian valve, guarding the opening of the coronary sinus. This commissure passes forward through this muscular septum between the opening of the coronary sinus and the oval fossa, and this muscular septum is called the sinus septum. This tendinous structure passes forward through the sinus septum and inserts here to the base of the aorta. And this fibrous structure is called the tendon of Todorov. That forms the atrial margin of the triangle of Koch. The ventricular margin is formed here, where the septal leaflet of the tricuspid valve takes its origin from the atrioventricular junction. And the base of the triangle is formed here at the mouth of the coronary sinus. So the triangle of Koch, formed between tendon of Todorov, attachment of the septal leaflet of the tricuspid valve, mouth of the coronary sinus, has at its apex the atrioventricular node. And then the atrioventricular node penetrates through the insulating plane of tissue, which at all other points separates atrial myocardium from ventricular myocardium, and reaches the left ventricular outflow tract. The structure which penetrates this tissue plane is called the penetrating atrioventricular bundle, or the bundle of His. Now I can show you the location of this bundle of His much better in another heart, which I have dissected to show the arrangement of the atrioventricular junctions. This is an important view of the cardiac anatomy that I'm showing you at the moment, and it is one that I hope you will all recognize by now. Here you see the aorta lying centrally within the short axis of the heart. You will appreciate that we're looking down on the atrioventricular junctions from above, and that I have cut away the atrial tissues, the root of the aorta, and the trunk of the pulmonary outflow tract. And here is the pulmonary trunk originating anteriorly and leftwards from the left ventricle. So as we look down on this short axis, this is the left side, which I'm indicating at the moment. This is the diaphragmatic surface of the heart. The right side here, and centrally located, wedged between the mitral valve and the tricuspid valve, we have the aortic root. Now you will note that I have also cut away the non-coronary sinus of the aortic valve. Here is the right coronary sinus, giving rise to the right coronary artery, the left coronary sinus, giving rise to the left coronary artery. Having cut away this non-coronary sinus, I'm able to demonstrate to you this very deep diverticulum which separates the mitral valve. I'm putting emphasis on the aortic leaflet of the mitral valve. This separates the aortic valve from the septum. And the consequence of this, as you can see very beautifully, is that because of this separation between mitral valve and the septum, the tip of the ventricular septum here beneath the area of the membranous septum, and there very beautifully you see springing into prominence is the membranous septum, crossed here by the septal leaflet of the tricuspid valve, dividing the membranous septum into atrioventricular and interventricular components. Because of this wedged position of the aortic valve and the lifting away of the mitral valve, it is but just a short distance from the apex of the triangle of Koch to the left ventricular outflow tract. This, you will appreciate, is the vestibule of the right atrium. You see beautifully here the pectinate muscles that are running all the way round the right atrioventricular junction. And here you see the three leaflets, the tricuspid valve, the septal leaflet, the very large anterosuperior leaflet, and the much smaller inferior leaflet. Here you will appreciate the mitral valve with its deep aortic leaflet, its much shallower, but much longer mural leaflet. And here you will appreciate the septal area. I have cut away the atrial tissues, but here is the remnant of the atrial septum. This is the location of the mouth of the inferior cable vein. and therefore you will recognize here the eustachian valve, and you see that if I put tension on the eustachian valve, as we just discussed, that tension brings into prominence the tendon of Todaro. There is the tendon of Todaro, and that in turn demarcates the location of the triangle of Koch. You will appreciate also that here is the mouth of the coronary sinus, and guarding the mouth of the coronary sinus is the remnant of the Sabesian valve. And this now shows you very beautifully the location of the atrioventricular node, the apex of this triangle of Koch, and illustrates to you what a short distance it is for the atrioventricular bundle to pass from the apex of the triangle of Koch through the membranous septum to reach the crest of the muscular septum. Having reached the crest of the muscular septum, the bundle then immediately branches on the muscular septum. The right bundle branch passes back through the septum, where it emerges here beneath the medial papillary muscle, and then the right bundle branch passes down within the structure of the septomarginal trabeculation before ramifying at the ventricular apex, with one of its branches passing across the cavity of the right ventricle, the moderator band, whereas the left bundle branch ramifies on the smooth septal surface of the left ventricular outflow tract, having passed into the left ventricular outflow tract. Here in the commissure between the non-coronary leaflet of the aortic valve, which I'm indicating at the moment, the right coronary leaflet here, and this is the location of the membranous septum, which I showed you just a moment ago in that short axis of the heart. So the conduction bundle will have penetrated through at this point, reached the left ventricular aspect of the septum. The left bundle branch will then fan out and descend on the smooth surface of the septum, and with the eye of faith we can see these white ramifications here that almost certainly represent the fibers of the left bundle branch. They pass down the septal surface before activating the ventricular myocardium at the apex of the ventricle. As I said quite some time ago, the structure of this atrioventricular conduction system is first to delay the impulse here in the atrioventricular node, and to do that the node has a compact compartment, compact zone found at the apex of the triangle of Koch, a small area of transitional cells around it. That is where the major part of the delay occurs. Once the node has delayed the impulse, the ventricles are filled with blood. The impulse is then able rapidly to pass through the penetrating bundle to be disseminated immediately, or virtually immediately, to the ventricular apex in the right bundle branch and in the left bundle branch, and then to be rapidly disseminated throughout the ventricular myocardium by the so-called Purkinje fibers, and those Purkinje fibers then activate the ventricle to drive the blood up the arterial trunk by contraction of the ventricle from the apex towards the base. So if we return to our short axis of the heart and we look at it in its broadest context, in the normal heart, the only muscular connection passing from atrial to ventricular myocardium is found here at the apex of the triangle of Koch. Elsewhere, all the way around the tricuspid orifice, around the mitral orifice in the normal heart, there is a tissue plane which insulates the atrial from the ventricular myocardium. Now there is an important arrhythmia which occurs when, in certain congenitally malformed hearts, other muscular structures pass from the atrial to the ventricular myocardium. That abnormal rhythm is called Wolff-Parkinson-White syndrome, and the Wolff-Parkinson-White syndrome can be caused by one of these muscle bundles, no thicker than a piece of cotton, which can cross over this tissue plane at any point around the mural leaflet of the mitral valve, at any point within the ventricular septum, particularly here in the tissue plane beneath the mouth of the coronary sinus, or at any point around the parietal margin of the right atrioventricular junction. And if we turn back for a moment to our more complete heart, we know from histologic studies that these strands of myocardium, no bigger than a piece of cotton, almost always cross over the atrioventricular junction at a point such as I'm indicating with the point with my probe at the moment, very close to the origin of the mitral valve and traversing through this fibro-fatty tissue plane. Those muscle bundles can occur anywhere within the mitral orifice, anywhere within the tricuspid orifice, posteriorly beneath the floor of the coronary sinus, or within the septum itself. There has been some confusion recently in that a lot of electrophysiologists have described this area, which I'm showing you again now in the short axis of the heart, this area between the anterior wall of the right atrioventricular junction and the right coronary sinus of the aorta, has been described as the so-called anterior septum. In reality, this area is the roof of the supraventricular crest. It is part of the parietal right atrioventricular junction, and this should not be construed as a septal area. So the muscle bundles that can produce Wolff-Parkinson-White syndrome can exist anywhere around the mural leaflet of the mitral valve. You will note that they do not exist in relation to the anterior leaflet of the mitral valve, because that has no myocardium beneath it. Since if we look at the ventricle from beneath, we see, as you are all aware, the fibrous continuity between the leaflet of the anterior part of the mitral valve, the leaflets of the aortic valve. There is no muscular continuity across that aortic leaflet, so there is no potential for accessory connections at this point. Or if we look at it from above, in this point of the left atrial myocardium, related to the aortic leaflet, but at any point around the mural leaflet, continuity is possible. Continuity is possible in the posterior part of the septum, particularly related to the mouth of the coronary sinus, or continuity is present anywhere around the right atrioventricular junction. We know from electrocardiographic studies that those connections that exist here within the left AV junction produce so-called type A Wolff-Parkinson-White syndrome. Those within the right atrioventricular junction produce so-called type B Wolff-Parkinson-White syndrome, where those that are found around the mouth of the coronary sinus can penetrate either to the left or to the right, so they can form either A or B variants of Wolff-Parkinson-White syndrome. So in these normal hearts, I've tried to demonstrate to you the course of the conduction system as it exists and as it is changed by the presence of accessory connections in Wolff-Parkinson-White syndrome. Because in these hearts with accessory atrioventricular connections, the presence of the accessory connection enables the ventricle to be excited earlier than would be the case through the impulse passing through the normal conduction tissue. And so the effect of the Wolff-Parkinson-White syndrome, the effect of this pre-excited area of ventricle, is to produce first a shortening of the PR interval, and second, a fusion beat between the pre-excited area and the normally excited area. So it is easy then to account for Wolff-Parkinson-White syndrome and its effects upon the heart. Let us now, however, turn our attention to the effect that congenital malformations have upon the conduction system. Wolff-Parkinson-White in itself is a congenital malformation, since the presence of an anomalous muscle bundle across the atrioventricular junction at any of the points I've just indicated must be and is a congenital malformation. But the conduction tissue itself can be abnormally disposed because of the presence of lesions within the heart. So let us now examine the effect of some of those lesions. You will, I hope, immediately recognize in this heart that there is a ventricular septal defect. You are all well aware now that ventricular septal defects are the commonest type of congenital cardiac malformation, existing in up to 30% of all congenitally malformed hearts, often in association with other lesions. The system we use for categorizing these ventricular septal defects enables the position of the conduction tissue to be predicted irrespective of the presence or absence of other associated lesions. Now, the feature of the heart that I'm showing you at the moment is that in its postero-inferior rim, and let me give you the landmarks to this heart so that you understand what I mean by the postero-inferior rim. Here is the tricuspid valve, here the apex of the right ventricle, here the outflow tract of the right ventricle, leading up in this heart to the pulmonary trunk. So here is the ventricular septal defect with its superior margin, its anterior margin, its inferior margin, and its posterior margin. Let us concentrate upon this postero-inferior corner of the defect. And if we focus in on that corner, we see that in this postero-inferior corner there is fibrous continuity between the leaflet of the aortic valve, which I am probing through the defect, and the leaflet of the tricuspid valve within the right ventricle. This fibrous continuity between arterial valve and atrioventricular valve is the feature which we use to describe this particular defect as being perimembranous. The defect extends around the area which ought to be filled by the membranous septum, and indeed here posteriorly we still see the remnant of the atrioventricular membranous septum. Now, I showed you that in the normal heart the conduction tissue penetrated from the apex of the triangle of Koch and passed behind the membranous septum to reach the apex of the muscular ventricular septum. And that gives us the clue in this heart as to where to expect to find the conduction tissue. Here is the opening of the inferior cable vein, and I'm lying my probe in that opening at the moment. And guarding the opening of the inferior cable vein, we see the eustachian valve. So in this heart, we can still work out the landmarks of the triangle of Koch. I'm now putting my probe in the mouth of the coronary sinus. We see that guarding that coronary sinus is the Thebesian valve. The eustachian valve joins with the Thebesian valve to form the tendon of Todaro, and the tendon of Todaro runs through the sinus septum between coronary sinus and oval fossa to reach the posterior margin in this heart of the ventricular septal defect. Here you see the septal leaflet of the attachment of the tricuspid valve. So at this point we find the apex of the triangle of Koch, and that is where we know the atrioventricular node will be. The atrioventricular node will then give rise to the bundle, which will penetrate here through the atrioventricular membranous septum and reach the crest of the ventricular septum, with the right bundle branch penetrating back through the septum to pass beneath this medial papillary muscle. So that information, the apex of the triangle of Koch, the location of the membranous septum, the medial papillary muscle, enables us to put in the course of the atrioventricular conduction axis. And then you see that in this defect, the defect itself will be above the conduction axis. Or to put it another way, whenever a defect has its posterior inferior margin made of fibrous continuity between the leaflets of an atrioventricular and an arterial valve, then always the conduction tissue will penetrate postero-inferiorly relative to the septal defect. For the surgeon, that means that if the surgeon is operating through the tricuspid valve, and here is the view that the surgeon might get looking through the tricuspid valve. There you see the anterosuperior leaflet, septal leaflet, here the coronary sinus. And this is the view of a ventricular septal defect the surgeon often gets. In looking down through the right atrium, he sees the ventricular septal defect. He identifies the posterior-inferior margin made of fibrous tissue, fibrous continuity between the aortic valve through the defect, tricuspid valve. As soon as he identifies that fibrous continuity, knows that the defect is perimembranous, he knows that the conduction tissue will be in this location, in other words, to his right-hand margin relative to the ventricular septal defect. And this rule holds good for any perimembranous ventricular septal defect in hearts with concordant atrioventricular connection. In this particular heart, as you see very nicely, the perimembranous defect extends so that it opens towards the subpulmonary outflow tract. But exactly the same would hold good with the conduction axis being to the right hand of the surgeon, even if the defect opened to extend towards the inlet of the ventricle or to extend towards the apical trabecular component. And so the rule for ventricular septal defects is that whenever the defect is perimembranous, the conduction tissue runs postero-inferiorly relative to the defect or to the right hand of the surgeon operating through the tricuspid valve. Now, in some hearts with ventricular septal defects, there is a muscular postero-inferior rim to the defect. This is very frequently seen in hearts with tetralogy of Fallot. The rules I have shown you hold equally well for tetralogy of Fallot as they do for the isolated heart. I'm now showing you rather a small heart that has tetralogy of Fallot. The feature of tetralogy of Fallot, as you all know, is anterocephalad deviation of the outlet septum. Here is the tricuspid valve in this heart, the apex of the right ventricle. I've opened it to show you the subpulmonary outflow tract, and this heart has been the subject of surgical repair. So there has been resection of muscle here in the region of the septoparietal trabeculations. There's been resection of muscle here where the outlet septum joins the ventriculo-infundibular fold. You see that the surgeon has also put in a patch to enlarge the subpulmonary infundibulum. But we are still able to see the essence of tetralogy, which is anterocephalad deviation of this body of the outlet septum relative to two limbs of the septomarginal trabeculation. Now the defect that you are seeing here, into which I've just put the probe of my knitting needle, is an unusual defect in tetralogy, because if we look at it carefully, this posterior limb of the septomarginal trabeculation fuses with the ventricular infundibular fold here in this postero-inferior rim of the defect. We know that this is the area occupied by the conduction tissue. If we open up the tricuspid valve and we look from the right atrium, we see coronary sinus, we see the location of the triangle of Koch, septal attachment of the tricuspid valve, the apex of the triangle of Koch. And we know that in this heart, the bundle will penetrate at this position and run to pass beneath the medial papillary muscle. And there, very nicely, you see the medial papillary muscle arising from the posterior limb of the septomarginal trabeculation. The effect of this muscle bundle reinforcing this posterior-inferior rim of the defect will be to protect the conduction tissue penetrating at this point. The conduction axis will still be postero-inferior relative to the defect, but because there is this muscular reinforcement of the posterior-inferior rim, which in this instance is 2 or 3 millimeters in dimension, the surgeon will be able to use this muscle to anchor his sutures in this location and thus avoid the bundle. So the presence of a muscular rim in a defect opening to the outlet of the right ventricle, a muscular rim which is located posterior-inferiorly, is to reinforce and protect the conduction axis so that the surgeon is able to use this muscular posterior-inferior margin as an anchorage for his sutures. And this holds good for all defects opening to the outlet of the right ventricle, be they muscular, as we see in this heart, or doubly committed in juxta-arterial. Now, the rules for such muscular defects clearly depend upon the location of the triangle of Koch and the medial papillary muscle. We can use those rules very usefully in another heart that has a muscular ventricular septal defect and show how there is a very important variation in the course of the conduction tissue depending upon the location of muscular defects within the substance of the ventricular septum. We're looking now again at a rather small heart. You will recognize the right atrium. Beautifully, we see the pectinate muscles within the right atrium and passing the probe into the mouth of the superior cable vein. Here the inferior cable vein, large oval fossa, the mouth of the coronary sinus. Here is the apex of the triangle of Koch, and that is going to mark the location of the conduction tissue. Here is the medial papillary muscle, and we've turned our attention now to the right ventricle. The black hole is the subpulmonary outflow tract. Here is the ventricular infundibular fold, the anterosuperior leaflet of the tricuspid valve. So if we join the apex of the triangle of Koch, the medial papillary muscle, we can mark in the location of the conduction tissue. But now look at the position of this muscular ventricular septal defect. The muscular ventricular septal defect in this instance opens to the inlet of the right ventricle. And because of the presence of this defect in subtricuspid position, now the conduction axis will pass antero-superiorly relative to the margin of the ventricular septal defect. And if the surgeon was approaching this muscular defect through the tricuspid valve, then the potential danger area would be totally reversed relative to the typical perimembranous defect. Let us return just for a moment to the perimembranous defect, and let's look at that once more as the surgeon would see it through the tricuspid valve. Remember, in this defect, the fibrous posterior inferior margin says that the conduction tissue is related to the right hand margin of the defect. And it is the postero-inferior corner of the defect itself which is the major danger area. contrast that arrangement with what we have just seen in the heart with the muscular inlet ventricular septal defect. Now, because the defect surrounded by muscle opens to the inlet part of the right ventricle, the conduction axis is to the left hand, the left margin of the ventricular septal defect. The bundle penetrates at the apex of the triangular cock. The right bundle branch is now related to the medial papillary muscle, and relative to the defect itself, we put the heart in anatomic location, the conduction axis is antero-superior. No longer postero-inferior, as is the case for the perimembranous defect, but antero-superior. And so because of that, returning the heart to its surgical orientation, it is the left-hand margin of the defect which is closest to the conduction axis and which is most at risk. In this particular heart, as you see, there is a significant area of muscle between the medial papillary muscle and the rim of the defect. So it is most unlikely that in this heart, had the surgeon tried to close this with a patch, that stitches placed around the margin of this defect would have had any danger at all for the conduction axis. But if this defect had become larger and had eroded closer towards the membranous septum, which is still present in this heart, in the area of the anteroseptal commissure, then the conduction axis could potentially have been at risk, and it would then have been crucial for the surgeon to identify a muscle bar such as this, telling him that for the muscular defect, it is the left-hand margin, the antero-superior margin of the defect that is at risk, whereas had this perimembranous defect open to the inlet of the right ventricle, it would have still have been the posterior-inferior margin or the right-hand margin seen through the tricuspid valve. It would have been at risk. And these rules hold good for all ventricular septal defects in hearts with concordant atrioventricular connections. Now let us shift tack just a little bit and look at another very common and another very important congenital malformation. I hope you will immediately recognize this as an atrioventricular septal defect. We're looking at this from the right side. Here is the inlet of the right ventricle. You see the common atrioventricular valve, and you will recognize in this particular heart the superior and the inferior bridging leaflets. You will see that there is a space between the bridging leaflets, and you'll see that there is a ventricular communication beneath the superior bridging leaflet, and also beneath the inferior bridging leaflet. This is an atrioventricular septal defect with common atrioventricular orifice. Now, I've explained to you how, in the normal heart, the penetrating bundle passes through the atrioventricular component of the membranous septum. In this heart, of course, there is no atrioventricular septum. Another consequence of that is that the aortic outflow tract is anteriorly deviated relative to the scooped out crest of the ventricular septum. I've now opened the heart to show you the left ventricular aspect of this defect, and you see the deeply scooped crest of the ventricular septum. We know that the conduction axis ascends on the crest of the ventricular septum, and so with this large atrioventricular septal defect, the conduction tissue is no longer going to be related to the subaortic outflow tract, as was the case in the normal heart. Because of the total absence of any atrioventricular septal structures, it is no further use to have a node at the apex of the triangle of Koch. If we look at this heart, as is the case with very many atrioventricular septal defects, we see that the atrial septum itself is relatively well formed. Here is the oval fossa, here is the coronary sinus, here is the tendon of Chodorow, passing between the two to form a regular triangle of Koch. But also you see that it is no point in this heart having an atrioventricular node at the apex of this triangle of Koch, because the node wouldn't go anywhere. Instead, to find the location of the atrioventricular conduction axis in atrioventricular septal defects, we follow back to the crest of the ventricular septum to see where it meets the atrioventricular junction. And in atrioventricular septal defects, in the majority of cases, the ventricular septum meets the atrioventricular junction here at the crux of the heart. And opening into the atrial tissue at this area of the crux of the heart is the coronary sinus, and that enables us to recognize a separate nodal triangle. This nodal triangle is delimited by the leading edge of the atrial septum, the attachment of the inferior leaflet of the common atrioventricular valve. And where the atrial septum meets the midpoint of this inferior bridging leaflet, that is where we find the atrioventricular node. So the node in atrioventricular septal defects is displaced posterior-inferiorly with a long non-branching bundle ascending the crest of the ventricular septum here beneath the inferior bridging leaflet. The right bundle then passes from the crest of the septum in the space between the two bridging leaflets and enters the right ventricular outflow tract, where once more it emerges beneath the medial papillary muscle. The left bundle branch descends from the midpoint of the ventricular septum. Again, we see these areas which probably represent the ramification of the bundle here on the smooth side of the septum, running down beneath the inferior bridging leaflet, and the consequence of this is that the subaortic outflow tract, located anterosuperiorly, is no longer related to this area of descent of the left bundle branch. So in atrioventricular septal defects, it is absence of the atrioventricular septum which forces the conduction tissue posteriorly, so that the bundle takes origin from an atrioventricular node here in a nodal triangle at the crux of the heart. The rules for locating the conduction tissue are to trace the ventricular septum up until it meets the atrioventricular junction. If that is then adjacent to atrial myocardium, that will be the point of formation of the atrioventricular node. Now we can trace that, we can follow that rule in another very important malformation. Here is a heart that we're looking at anteriorly from the right ventricle. It has a narrowed subpulmonary outflow tract. It has a deviated outlet septum. In other words, it has tetralogy of Fallot. But if I take away the front part of the heart, I can then show you another very important associated malformation with this heart. Because here is the mitral valve coming from the left atrium. Here is the tricuspid valve. And you see that the orifice of the tricuspid valve overrides the ventricular septum. The leaflets of the tricuspid valve straddle the ventricular septum. And here is a papillary muscle within the left ventricle that is supporting the leaflets of both the mitral and the straddling and overriding tricuspid valve. Now, what is the consequence of this for the conduction tissue? Here you see the eustachian valve and the triangle of Koch. and that comes together normally into the atrial septum. But you see that at the lower edge of the atrial septum there is nothing, because the consequence of overriding and straddling of the tricuspid valve is malalignment between the atrial septum and the ventricular septum. Let us now follow the rule I just produced for you concerning the course of the conduction tissue. The conduction tissue runs along the posterior septum until it meets the atrioventricular junction. In this heart, that meeting point between ventricular septum and atrioventricular septum is distant from the atrial septum. I'm sorry, I made a mistake there. I meant to say the junction point between ventricular septum and atrioventricular junction is distant from the atrial septum, so that the regular node in the apex of the triangle of Koch will no longer be able to make contact with the conduction tissue on the ventricular septum. Instead, there will be an anomalous atrioventricular node formed here at the point where the backward extension of the ventricular septum comes up and joins the atrioventricular junction. So this is one of those important anomalous hearts, important variations where the atrioventricular node is no longer in the apex of the triangle of Koch, but is postero-inferiorly located within the atrioventricular junction. And the key to this anomaly is malalignment between the atrial and the ventricular septal structures. I can now show you another very important heart that has a similar abnormal arrangement of the atrioventricular node. This is a heart, as you see, with its apex pointing to the right. It's also a heart in which the aorta arises from the left-sided ventricle, which has very coarse apical trabeculation. In other words, the aorta is arising from the morphologically right ventricle, which is left-sided. The atrial chambers are usually arranged. Here is the left-sided atrial appendage, which is a morphologically left atrial appendage. So the left atrium is passing through a distorted and deformed tricuspid valve to the right ventricle, whereas the right atrium, in its normal location on the right side, is passing through a mitral valve into the morphologically left ventricle. In other words, the heart has discordant atrioventricular connections. The heart also has discordant ventricular arterial connections. I've just passed my probe up into the pulmonary trunk from the left ventricle, whereas the aorta, as we've already seen, springs from the right ventricle. The aorta from the right ventricle is transpositioned. The discordant atrioventricular connections correct the discordant ventricular arterial connections. So here we have corrected transposition. Note also, however, the consequence of this location of the pulmonary trunk posteriorly within the left ventricle. That lifts the atrial septum here away from the ventricular septum. And because this atrial septum here is lifted away from the ventricular septum by this deeply wedged location of the pulmonary outflow tract, the conduction tissue here on the ventricular septum is no longer able to reach the atrial septum. So the conduction tissue in corrected transposition does not go posteriorly to the crux of the heart. Instead, conduction tissue, which you can see here as a white area, gives rise to a bundle which passes in front of the ventricular septal defect and reaches an anterior node here beneath the mouth of the right atrial appendage. So in corrected transposition, as in straddling tricuspid valve, no longer is the connecting node here at the apex of the triangle of Koch, but because the septum comes up towards the atrioventricular junction anteriorly here, the point of formation of the atrioventricular node is here at the anterolateral commissure between the pulmonary and neural leaflets of the mitral valve. The atrioventricular node is there. The bundle penetrates to reach the anterior margin of the septum, passes anterosuperior relative to this perimembranous inlet ventricular septal defect, and also anterosuperior relative to the subpulmonary outflow tract. I can now show you one final heart which has this crucial arrangement of septal malalignment to complete our discussion of this abnormal disposition of conduction tissues. This again is a very small heart. In this instance it has a rudimentary and incomplete right ventricle that I'm showing you at the moment. The ventricle is on the leftward shoulder of the heart. It has an apical component, an outlet component supporting the aorta. If we look at the dominant ventricle, we see that that dominant ventricle has a very smooth septal surface and fine apical trabeculation. In other words, it is a dominant left ventricle. And as we see in the inlet component, the dominant left ventricle receives both atrioventricular valves. Because the septum is positioned anteriorly, here we see that anterior apical trabecular part of the septum. Here is the outlet part of the septum, separating the posterior pulmonary trunk and the anterior aorta. Because all of those septal structures are anteriorly within the heart, there is no septum here beneath the atrial septum. Gross malalignment between atrial and ventricular septal structures. So once more, there is no point in having a node within the apex of the triangle of Koch. And, as in corrected transposition, the node is situated beneath the mouth of the right atrial appendage. The bundle penetrates to reach the anterior part of the septum, descends in that position, passes above the ventricular septal defect as viewed from the dominant left ventricle, but if viewed from the rudimentary right ventricle, passes postero-inferiorly. So here is another situation where the node is located anterolaterally because there is no tissue beneath the atrial septum to receive the conduction tissue. Should the surgeon wish to enlarge this ventricular septal defect, he would take out a wedge of tissue closest to the acute margin of the heart. So from all the hearts I have been showing you, the rule that emerges is that the location of conduction tissue is found at the point where the ventricular septum comes up and meets the atrioventricular junction. And that is the message from the demonstration.
Good afternoon, ladies and gentlemen. The topic this afternoon is double inlet ventricle. But what do we mean by double inlet ventricle? Is it synonymous with so-called single ventricle with infundibular chamber, or common ventricle, or in the older terminology, cor biloculare? Well, we'll see, because double inlet ventricle really has to do with the sort of connection across the atrioventricular junction. As you can see on this chart, we have shown the heart with univentricular atrioventricular connection cut across to show the variation of atrioventricular connections. And double inlet atrioventricular connection is just one variant of univentricular atrioventricular connections. So we can have double inlet ventricles, we can have absence of the right atrioventricular connection, which you're going to hear about next week, and we can also have absence of the left atrioventricular connections. And all these types of atrioventricular connections can exist in the setting of usual atrial arrangement, that is the usual combination, occasionally with mirror image atrial arrangement, and sometimes with isomeric arrangement of the atrial appendages. Now, in terms of ventricular morphology, there is also variability. The true single ventricle is a connection to a solitary ventricle which has indeterminate type of trabecular pattern. Much more commonly, it is a left ventricular dominant ventricle that we're looking at. And when we're talking about hearts with double inlet ventricle, we can describe double inlet to a dominant left ventricle in the presence of a rudimentary right ventricle. Similarly, we can talk about a double inlet to a dominant right ventricle in the presence of a rudimentary left ventricle. Now, what is a dominant ventricle and what is a rudimentary ventricle? Not purely on the size, but on the component makeup of the ventricles that we can use the terms dominant or rudimentary. The dominant ventricle, for instance, the dominant left ventricle, would have its full complement of components, which I'm sure you're familiar with. It has an inlet component, an apical trabecular component of left ventricular morphology, and an outlet component. Whereas the rudimentary ventricle, for instance, lacks one of its component makeups. And usually, in cases with univentricular atrioventricular connection, it is the inlet portion that is lacking, and you are left with the trabecular portion, which gives you the ventricular morphology, and you are usually also left with an outlet portion, although in some cases you may even have absence of the outlet portion. So by rudimentary ventricle, we mean a ventricle that is lacking one or two of its components. Now, what is the relationship between double inlet ventricle? Because that is what we are concerned about this afternoon, double inlet ventricles. What is the relationship between that atrioventricular connection and a connection, a biventricular atrioventricular connection? Now let us go to another chart and we'll see what happens. I have here a right-sided atrium and a left-sided atrium, and each atrial chamber is connected to its own respective ventricular chamber.